Hello, my name is John Sai from the UCI School of Medicine. In this video, we will be discussing hormones produced by the kidneys, hormones that regulate kidney function, and hormones that are affected by renal function and dysfunction. The kidneys are actually one of the larger endocrine organs in our body, and as you've already seen in the previous videos, hormones play a very important role in the regulation of our electrolytes. We will continue our discussion today on some of the other effects these hormones have in our body. So far in our videos, we have actually talked a lot about hormones. If you recall, we talked about the role of antidiuretic hormone in water and salt regulation in the first video. We then talked about the role of aldosterone in potassium regulation in the second video. And in the third video, we also discussed how aldosterone plays a role in acid regulation in our body. And finally, in this video, we will talk about some other hormonal effects on and by the kidney. These are the major hormones that are produced or have some effect on or through the kidney. These hormones feature very commonly in everyday clinical practice because they also have very far-reaching consequences outside of nephrology. Let's take the renin-angiotensin-aldosterone system, or RAS, for example. While the kidneys are the primary ignition point for regulation of the system, the lungs, liver, and blood vessels all have some role to play in the regulation of the entire system that is integral to regulating our blood pressure, blood volume, sodium, and potassium levels in our body. When we have too much fluid in our body, the natriuretic peptides become activated while the RAS system becomes deactivated. The kidneys are also important at calcium homeostasis via vitamin D metabolism, as we will see in this video. And lastly, our kidneys are also important at making the hormone erythropoietin that is essential for producing red blood cells in our body. We will continue to discuss each of these hormonal systems in more detail in the slides ahead. Let's go back to the renin-angiotensin-aldosterone system and take a closer look at all the moving parts. You will no doubt have already learned about this pathway in your other blocks, so hopefully this will be a review. Let's start on the left side. The kidneys are responsible at sensing any changes in blood volume, and they do this primarily through sensing renal perfusion and sodium delivery in the juxtaglomerular apparatus. We will discuss more in depth about how this works in the next couple of slides. In response to a decrease in blood volume, the hormone renin is produced. Renin is then responsible for helping convert angiotensinogen, that is produced by the liver, to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2, primarily in the lungs by the angiotensin-converting enzyme, or ACE. Angiotensin 2 then has multiple pleiotropic effects throughout the body, including increased sympathetic activity and increasing arteriolar vasoconstriction, which will result in an increase in blood pressure. Angiotensin 2 is also responsible for stimulating the adrenal cortex at producing the hormone aldosterone, which will increase sodium reabsorption in the diastolic tubule, as we have discussed in the previous video. In addition, angiotensin 2 can also help stimulate production of antidiuretic hormone, or ADH, that will stimulate reabsorption of water. All of these effects make sense in the setting of decreased effective arterial blood volume. This hormone cascade triggers an increase in blood pressure and stimulates the body to reabsorb as much of the water and salt as possible to increase the effective circulating volume so that perfusion to the juxtaglomerular apparatus improves and hopefully will then decrease the production of renin. As you can expect, once our blood volume is replete, renin production ceases with a concomitant decrease in aldosterone and ADH levels that then result in more sodium and water wasting from the body, especially in times of volume excess. So basically, remember that low volume states activate the RAS system. Renin and aldosterone levels are expected to be elevated in the setting of low effective arterial blood volume. This system is a very important system for you to know, not only because of its many effects throughout the body, but because there are so many medications that target almost all the items in this pathway. Since this pathway deals a lot with blood pressure, you can imagine that any blockage of this pathway with medications will result in a decrease in blood pressure, and this is primarily the activity of these medications. We have already talked about some medications that block the aldosterone receptor and the antidiuretic hormone receptor, but there are also direct renin inhibitors, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and most recently, aldosterone synthase inhibitors. Knowing the system well can help with understanding how the medications we use to block the system to have their intended effects, and also help to understand the primary side effects that these medications can have. Let's take a closer look at where renin is produced in the kidney. The macula densa cells sit at the top of the thick ascending limb of the loop of Henle and the distal convoluted tubule, and it is this that is responsible for sensing the sodium chloride concentration in the tubules. In response to low sodium chloride concentration levels, when you have lower perfusion to the kidneys, this triggers a cascade of events in the macula densa that lead to production and increase in renin levels, as well as afferent arteriolar vasodilation to increase GFR and renal plasma flow. Conversely, in high sodium chloride concentrations, this decreases stimulation and production of renin. The lower renin levels allow for vasoconstriction and lower reabsorption of sodium in water. Every year, this mechanism is a bit confusing for some students, so let's take a deeper dive into the mechanisms of this interesting section of the kidney. Here we are again with a map of where we are in the kidney. The macula densa is a collection of cells located in the distal convoluted tubule and the end of the ascending limb of the loop of Henle that are responsible for sensing sodium and chloride, though it is thought to respond more to chloride levels than sodium levels. Upon sensing a low sodium chloride level, they signal to the granular cells in green to produce renin, along with prostaglandins that result in a vasodilation effect on the afferent arteriole. The vasodilation allows an increase in blood flow to the glomerulus. In the absence of any changes in the efferent arteriole, this results in a higher renal plasma flow, as well as a higher glomerular filtration rate. This hopefully increases the sodium chloride delivered to the macula densa to then signal a reversal of the changes and vasoconstrict the afferent arteriole again. This is an even more granular view of the mechanisms responsible for production of prostaglandins and renin. The chloride is sensed from the chloride transported into the cell by the NAK2Cl receptors in the macula densa. In the setting of high chloride, the nitric oxide to COX-2 production process is inhibited. But in low chloride states, this pathway is activated, resulting in COX-2 and prostaglandin production. The prostaglandin then goes to the juxtaglomerular cell to activate a cAMP pathway, which then results in the production of renin, which is then released into the bloodstream, where it can go to the liver to help convert angiotensinogen to angiotensin 1, thus activating the RAS pathway. We know a couple of medications that could potentially affect this pathway, the first of which are loop diuretics that block the NAK2Cl cotransporter. In this case, one would think that the pathway would be disrupted, and this is exactly what happens. With loop diuretics, lower chloride is sensed in the macula densa, which results in higher production of COX-2 and prostaglandins that then result in renin production. Interestingly, this is the mechanism that is thought to produce diuretic resistance, as the body tries to fight the effect of diuretics to increase reabsorption through aldosterone and ADH production from the increase in renin production that is stimulated. The other medication that affects this pathway that probably comes to mind are non-steroidal anti-inflammatory medications, or NSAIDs, specifically COX inhibitors. These are pain medications, but they also have side effects in the kidneys, mainly through the decrease in production of prostaglandins that then result in a decrease in renin production. This decrease in renin production leads to the afferent arteriolar vasoconstriction, which then leads to a decrease in GFR and renal perfusion. This explains a very important nephrotoxic side effect of NSAIDs, which is that it decreases renal perfusion temporarily. In the setting of chronic NSAID use and volume depletion, this can result in permanent kidney damage through a sustained decrease in renal perfusion. The RAS system is so important that there have been several medications developed and designed to block different pathways of this system. But in order to understand why there have been so many medications targeting this system, we have to understand what happens when there's an overactivation of this system first. When any of the RAS components are produced in significant amounts, this generally tends to lead to a higher amount of aldosterone. The high aldosterone levels lead to an attachment of the mineralocorticoid receptor, which then causes translocation of the ENaC channels to the luminal surface. This results in an increase in sodium reabsorption, and an increase in potassium excretion. The sodium reabsorption can also lead to water reabsorption as water almost follows salt, and this can cause hypertension after prolonged periods of time. Indeed, we do see this case with hyperaldosteronism. Increase in sodium reabsorption leads to hypertension, increase in potassium excretion, which leads to hypokalemia, and because potassium excreted in the collecting duct, recall that there's an additional exchange for protons with potassium through the H plus K plus ATPase, which leads to an excretion of aldosterone-mediated protons, causing metabolic alkalosis. Hence, this forms a typical triad that we see in hyperaldosteronism of hypertension, hypokalemia, and metabolic alkalosis. We will come back to this concept in further details when we review our case studies, but this is an important concept to remember. Now let's get back to our medications. The RAS system is an important mediator in high blood pressure, and activation of any of these pathways, whether physiological or pathological, will eventually cause hypertension. Hence, blocking any of these pathways potentially has the effect of lowering blood pressure, and this is exactly what all these medications have been designed to do. First, we have the direct renin inhibitors that directly inhibit the renin enzyme, which blocks the conversion of angiotensin to angiotensin 1. Next, we have angiotensin converting enzyme inhibitors, or ACE inhibitors, designed to block the conversion of angiotensin 1 to angiotensin 2. Then we also have angiotensin receptor blockers that block the action of angiotensin 2 on the angiotensin 2 type 1 receptor, or AT1R, that mediates the action of angiotensin 2 to increase blood pressure and peripheral vasoconstriction. We also have mineralocorticoid receptor blockers, such as spironolactone, which block the direct action of aldosterone on the mineralocorticoid receptor. Lastly, we have novel medications called aldosterone synthase inhibitors, which block the production of aldosterone. You would think that blocking the last step, the mineralocorticoid receptor blockers, potentially has the best effects, but this is actually not the case. Because angiotensin 2 has so many other effects that may affect blood pressure, the strongest of these medications will tend to be your ARB or ACE inhibitors. While you think that we are done finding all the medications to block this pathway, there are actually new agents coming onto the market as of this year, such as aldosterone synthase inhibitors. This poses an alternative pathway in which we can block yet another path of the RAS system. We've spent a lot of time on the RAS system, but now let's talk about another important hormone that has some effects at maintaining volume in our body, which are the natriuretic peptides. Natri refers to salt and uretic refers to in the urine, so you can imagine that these hormones have some effect that results in more salt in the urine. While the RAS system deals with low volume, the natriuretic peptides deal primarily with high volume states and are produced when our body sends too much fluid in the body. Atrial natriuretic peptide, or ANP, is produced in the cardiac atria as a response to stretch receptors. When there's an increased venous return to the heart, the atria are stretched, leading to a production of atrial natriuretic peptide. This results in peripheral vasodilation to help decrease blood pressure and also nudges the kidney to excrete more sodium to get rid of extra volume. It does this by increasing glomerular filtration rate and decreasing renin and aldosterone production. Similarly, brain natriuretic peptide is also produced in states of high volume through stretch receptors in the brain. With high volume, an increase in BNP is produced, which leads to similar activity as ANP and results in increasing urinary volume, vasodilation in the peripheral vasculature, and of course, increasing sodium wasting, hence the term natriuretic property of BNP. We clinically use BNP as a lab test to help us determine if a patient is volume overloaded or not, especially in complicated cases of heart failure. While it is not the best marker for volume status, elevated BNP levels can suggest high volume status and can prompt us to use diuretics to help our body get rid of more water quickly to help improve the volume status of patients. Let's pivot away from hormones that relate to volume and talk about calcium metabolism. One usually doesn't think of nephrology as being related to calcium metabolism, and perhaps our endocrinology colleagues would concur, but the kidneys are important players in vitamin D metabolism that make nephrologists integral at helping manage bone health, especially in patients with chronic kidney disease. The primary renal importance of calcium metabolism lies in the conversion of the inactive 25-hydroxyvitamin D to the active 1,25-dihydroxyvitamin D. This is the last step in activation of vitamin D and is crucial to allowing vitamin D to have its intended effects on the bone and the gut. At the beginning of its life, vitamin D is either ingested as a supplement or produced naturally in the skin after exposure to UV light. This forms the first form of inactive vitamin D. The liver is then responsible for hydroxylation of vitamin D to 25-hydroxyvitamin D. And finally, through the activity of 1-alpha-hydroxylase enzyme, the 25-hydroxyvitamin D is converted to active 1,25-dihydroxyvitamin D. It is only this form of vitamin D that results in calcium absorption from the gut and calcium regulation through effects on the bone that lead to calcium absorption. This active vitamin D also leads to an improvement in bone health over time. The next major organ in the cycle are the small parathyroid glands that sit right behind the thyroid glands in the neck. We have 4 of them, and they are exquisitely sensitive to both vitamin D and calcium levels in the body. The parathyroid hormone is produced in this gland, and the hormone acts at the level of the bone and the kidney to help increase the calcium in the serum. In the bone, PTH causes bone resorption to release calcium and phosphorus into the bloodstream. At the level of the kidney, it acts at the distal tubule to decrease calcium excretion and increase calcium reabsorption in an attempt to increase calcium in the serum. Let's see how this works in the hormonal cascade. Let's say that the serum calcium levels are low. In this case, we want our body to try to release calcium from stores and reabsorb calcium from the kidney instead of allowing it to be excreted. There's a calcium sensing receptor in the parathyroid gland called a CASR that is activated with calcium. In the absence of calcium or low calcium levels, the CASR is not activated and allows the PTH levels to start to rise. This increases the parathyroid hormone level, and it does a few things. First, PTH increases conversion of 25-hydroxyvitamin D to active 1,25-dihydroxyvitamin D. And then it goes to the bone and kidneys to release calcium and reabsorb calcium as we discussed. All these effects help bring calcium levels back up to normal, and once normalized, the PTH production then stops. Let's talk about when things go wrong. You can imagine that if you have either liver or kidney failure, the entire vitamin D pathway is broken. Patients with kidney failure cannot produce active forms of vitamin D, which ultimately result in low calcium levels in the body. The low calcium levels then stimulate high PTH production, but because there is no kidney function to convert inactive to active vitamin D, the high PTH levels persist, and the pattern we typically see is low calcium and high PTH levels due to what is known as secondary hyperparathyroidism. I'm also including a great paper from 2010 that can be used as an additional resource if you want to know more about vitamin D and calcium metabolism. It goes into a lot of studies done on vitamin D, which is not necessary for you to know now, but may be an interesting read nonetheless. That was a lot of information, so let me summarize it here more succinctly for you. In the study of chronic kidney disease, the inability to convert vitamin D to active 1,25-dihydroxyvitamin D due to low muscle mass results in a decrease in calcium reabsorption from the gut. This causes eventually low calcium levels that go back to the parathyroid gland to increase PTH production. The PTH increase then leads to resorption of calcium from bone to help increase the serum calcium levels. Usually this may be enough to get to normal calcium levels in earlier stages of CKD, but in more advanced stages of CKD, there's usually not enough calcium that can be released into the bloodstream to maintain a normal calcium level. Hence, we typically still see the combination of low calcium and high PTH in chronic kidney disease, and again we term this secondary hyperparathyroidism since it is secondary to chronic kidney disease. This contrasts with primary hyperparathyroidism, where the high PTH levels are due to an adenoma in the parathyroid gland that drive bone resorption and result in high calcium levels, since vitamin D levels are still active and can still reabsorb calcium from the gut. Lastly, let's talk about another important hormone produced in the kidneys called erythropoietin. Erythropoietin is responsible for increasing red blood cell production in the bone marrow and is usually produced in response to low oxygen levels sensed by the kidney. The discovery of this pathophysiological mechanism earned William Kaelin, Greg Semanza, and Peter Radcliffe the Nobel Prize in Medicine in 2019. This discovery has opened up an avenue to treat anemia both in nephrology and the hematology fields, which underscore the interconnected nature of nephrology with other subspecialties. Briefly, anemia leads to a decrease in oxygenation in the kidney. The absence of oxygen causes a transcription factor called HIF, or hypoxia-inducible factor, to translocate into the cell of the nucleus. To orient yourself, we are here on the bottom panel when looking at this picture. The HIF transcription factor attaches to the hypoxia response element, or HRE for short. This allows production of not only erythropoietin, but also increases metabolism of glucose and increases angiogenesis. The erythropoietin then stimulates red blood cell production in the bone marrow when iron is present. After we get an increase in hemoglobin and increase in oxygenation, the oxygenation allows hydroxylation of the HIF, we're in the top panel now, and the hydroxylation results in VHL conjugation and subsequent ubiquitination that then leads to degradation of HIF. You probably have also heard about VHL or von Hippel-Lindau in your hematology oncology course, since it's also considered a tumor suppressor gene. Abnormal variations in the VHL gene result in the HIF not broken down, resulting in angiogenesis that helps to improve solid tumors. While we don't yet have a cure for VHL syndrome, knowing the existence of this genetic mutation can help improve screening and survival of patients with this genetic mutation. Of course, there are other variables that are involved with red blood cell production, including the presence of iron and other factors responsible for maturation of red blood cells, but this is one of the major factors in our body that help regulate adequate hemoglobin and hematocrit levels in our body. In chronic kidney disease, when there is not enough nephron mass, insufficient erythropoiesis is present, resulting inevitably in anemia in the majority of these patients. In fact, if an advanced chronic kidney disease patient doesn't have anemia, one should work up for other causes of high hemoglobin levels, since this is a rare situation. Now, as you know, AI has garnered a lot of attention these days, and it's improving every year. AI also poses a potentially interesting way to learn medicine. There are some limitations to AI, especially with cutting-edge research, since most AI models have not accounted for new and updated research, but is actually pretty good at providing information that is relatively well established. If you have a chance, you can establish an account with any one of the available large language models such as ChatGPT, Claude, Bard, or OpenEvidence. One thing I like about OpenEvidence is that the information is derived from established medical literature, so it's less likely to hallucinate information compared to other LLMs. They are all similar in nature. Give it a prompt like provide an overview of how the kidneys regulate erythropoiesis, and then see the response. If you want further in-depth information, prompt it to give you more details on a specific area. Before you believe everything you see and think it's the greatest thing in the world, just be aware that these AI chatbots are a statistically based algorithm programmed to provide you with the highest statistically relevant information, regardless of the accuracy of the information it provides. Or some may say it can provide facts and other alternative facts. While AI is a great tool, I would just be cautious about believing everything you learn from ChatGPT or any non-medically trained AI statistical model. I've seen it give some false information before, even though AI algorithms will state it with such resolve. But it's getting better every year. I'll finish off with a question to solidify your knowledge. The medications lisinopril and benazepril are two very commonly used medications that are in the class of medications called ACE inhibitors. As you might have guessed, they work by blocking the angiotensin converting enzyme in the lungs and decrease conversion of angiotensin 1 to angiotensin 2. This can have effects later down in the cascade, and one very important side effect that clinicians must remember having to do with potassium levels. Now, knowing the pathway of the renin-angiotensin-aldosterone system, can you predict what the effect will be on potassium levels in the body after using lisinopril or benazepril? Pause the video here to think about the pathway and come up with your answer of how these medications would affect potassium levels. When you are ready for your answer, click play again. To answer this question, let's trace what happens when we block the conversion of angiotensin 1 to angiotensin 2. The decrease in angiotensin 2 leads to a decrease in all the effects that angiotensin 2 has, including sympathetic activity, arteriolar vasoconstriction, sodium reabsorption through the production of aldosterone, and water reabsorption through the production of ADH. Remember that potassium regulation is primarily affected by aldosterone levels, and if we aren't producing aldosterone anymore due to an upstream blockade in the hormonal pathway, this results in a lower activity of aldosterone. Recall also that aldosterone leads to sodium reabsorption through the ENaC channel, but also potassium excretion through that ROMK channel to maintain electron neutrality. If we aren't able to reabsorb sodium, then we aren't able to get rid of potassium, which ultimately leads to high potassium levels in the body with potassium retention. Hence, one of the major side effects of using lisinopril or benazepril, or any ACE inhibitor or medications that inhibit this pathway, is hyperkalemia. Thank you for joining me in this video. Let's recall that we have talked about the renin-angiotensin-aldosterone system, or the RAS, and how it regulates blood pressure, water and sodium reabsorption in states of low effective arterial blood volume. We then talked about the other side of the spectrum with production of atrial and brain natriuretic peptides in the setting of high blood volume. We then had a brief discussion on calcium and vitamin D homeostasis, as well as how our kidneys help us regulate erythropoiesis. I hope you all have a better understanding and appreciation of how the kidneys work, especially its interactions with other organs and parts of the body to maintain the homeostasis we need to continue long and healthy lives.